Start.
So are we good to start, sir? Dr. Sandeep, sir, are we good to start the session?
Yes.
Okay, okay, sir. So good evening and a warm welcome to all the dignitaries present here. Myself Shweta from Clearnet, assigned as a session assistant to ensure a seamless experience. Clearnet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clearnet is the digital partner for this event organized by National Neonatology Forum, and the topic of today's session is NNF Shine Week 3 Base Zone. So let's begin today's session, for which I would like to hand over the session to Dr. Sandeep, sir. Over to you, sir. Kindly proceed. Thank you.
Thank you. My slides are visible now?
Yes, it's visible, sir.
Okay.
Just to convert this into slideshow mode, sir.
Yeah. Is it fine now?
Yes, it's fine, sir.
Okay. Yeah. Good evening, respected sir and other faculties, and good evening to all the students attending. The topic for today is actually the care of low birth weight babies, right? So this topic is actually I would say quite a big topic. I'll try to do justice to the topic as much as possible. And for all the pediatric residents, it is actually, this is something you have to do day in and day out. Okay. So it is one of the very basic topics, one of, the topics which would be helpful to you for, day-to-day practice. Okay. So, first of all, before we start about the care of the low birth weight baby, I'll give you a brief about what is actually, what do we mean by a low birth weight baby, and how do you classify a low birth weight baby, right? So, first we'll start with the definitions. So, as per the birth weight of the baby, we can classify a baby as having a normal birth weight, or the one which is having a low birth weight, or very low birth weight, or extremely low birth weight. Okay. So normally, the birth weight of a baby should be more than 2.5 kgs. Whenever a baby is born with a birth weight of less than 2.5, we call it a low birth weight baby. Whenever the birth weight is less than 1.5 kg or 1,500 grams, we call it a very low birth weight baby. Okay, and whenever the birth weight of a baby is less than 1,000 grams, we call it extremely low birth weight. Okay, so this classification is very important because every day in our day-to-day practice, while writing the diagnosis of the patients, or when you are dealing with the patients, you have to know which category the patient or the baby falls into. So it may be a low birth weight when the birth weight is between 1.5 to 2.5. When your birth weight is less than 1.5, we call it VLBW, and when it is less than 1,000 grams, it is called as ELBW, or extremely low birth weight. Then, as per the gestation, we classify these babies as, whenever the gestational age, normally it should be more than 37 weeks. Okay, so anything between 37 to 40 weeks is normal. Whenever the gestational age is less than 37 weeks of gestation, we call it a preterm. Okay, so any baby who is born at less than 37 weeks of gestation is called a preterm. Now, again, in that also, we have classified the preterms based on the weeks of gestation at the time of birth. We can classify them into something which is extremely preterm, or a very preterm, moderate preterm, late preterm, and then comes the term babies, right? So any baby who is born at a gestation of less than 28 weeks, we call it an extreme preterm baby. Whenever a baby is born between 28 to 32 weeks of gestation, the baby is called a very preterm baby. Whenever a baby is born between 32 completed weeks to 34 weeks, that is 33 weeks plus 6 days, then we call it a moderate preterm. And a baby who is born between 34 weeks to 36 weeks plus 6 days, that is between 34 to 37 weeks of gestation, then we call that baby a late preterm. Okay, and between 37 to 42 weeks, we call it a term baby, and more than 42 completed weeks, it is a post-term. So then coming to the types of low birth weight babies. Okay, so now again, a baby who is low birth weight, not necessarily maybe premature. Okay, there are sometimes babies who are born low birth weight, but maturity wise, their gestational age would have crossed 37 weeks. Okay, so that is why based on the weight alone, we should, based on the gestation alone, we cannot say that, based on the weight alone, we cannot say that the baby is preterm. Okay, so there may be some babies who are actually term babies, that is, they have crossed 37 weeks of gestation, but because of some compromise during the in utero phase, their growth was hampered, and as a result, their birth weight was less than what is expected at that gestation. Okay, so such babies we call as small for gestational age babies. Okay, so newborn can be a low birth weight predominantly because of these two reasons. One is a premature baby, that is a baby who is born at less than 37 weeks of gestation, and second is a baby who is born small for gestational age. Okay, so small for gestational age, there is a definition for this small for gestational age, also known as SGA. Okay, it is any baby who is born with a birth weight which is less than 10th centile for that gestational age and sex. Okay, so this we come to know when we plot the birth weight of the baby on the growth chart. Okay, so when we plot the birth weight of the baby on a chart, and if the weight of the baby at the time of birth falls less than 10th centile, we label the baby as SGA. Okay, so these SGA babies may be low birth weight. There may be some SGA babies who are small for gestational age, but still they would not fall below the weight of 2.5 kgs. Okay, and at the same time, there may be certain babies who are born premature, but their weight would be more than 2.5. Okay, so it is not necessary, but for all the babies who are born low birth weight, they may be either a premature baby or they may be a term baby, but who is small for gestational age. Okay, so this example shows you actually there is a mistake here in plotting. Uh, so this first point, so okay, I'll just show the chart to you. I mean, I think the chart is visible to all. So this chart, it actually shows growth chart. Okay, and on the growth chart, we have plotted the birth weight of the baby. Okay, actually the pointer here or the plotting is wrong in this chart. But suppose if the baby is born at say 36 weeks of gestation, okay, and the weight of the baby is say um, uh, 2.4 kgs. Okay, so when you plot this 2.4 kg, it comes somewhere here. Okay, and 2.4 kg at 36 weeks of gestation, it falls more than the 10th centile, but still it is less than 2.5 kgs. So we call the baby low birth weight. So this baby is low birth weight because of prematurity. Whereas if the same, if you take the example of point B, it is actually wrongly plotted. But if again at point B, if it is plotted, if it is again plotted at 2.4 kgs, and this time the baby is born at a gestational age of 38 weeks, then in that case, if you see, the weight of the baby is coming for less than 10th centile. Okay, now the baby is born at 38 weeks, which means that the baby is actually a term baby, but his weight is 2.4 kg, that is less than the 10th centile. Okay, so this baby is an SG or small for gestational age baby. Okay. So next, coming to what could be the risk factors for a preterm delivery. The risk factors for preterm delivery could be a history of previous premature birth. Okay, so we all know that if a mother has a history of a previous premature delivery, then there is very high chance that the subsequent pregnancies also she may have a premature birth. Okay, so the history of a previous premature birth is by itself a risk factor for subsequent premature deliveries. Second is when the mother is at extremes of age. Okay, so whenever a mother uh, conceives at say less than 18 years or more than 35 years, at both the extremes of age, there is a high chance that she may go in for preterm labor. Okay, third is a mother being underweight or overweight before or during the pregnancy. Okay, so there may be certain mothers whose pre-pregnancy weight would be say, I mean, we often see many mothers in our this thing practice, day-to-day practice, where the mother is actually only 30-32 kgs at the time of conceiving. Okay, so that is grossly underweight. And on the other hand, there may be certain mothers who at the time of conceiving, they had a weight of say 80-85 kgs. So that is grossly overweight. So both in both these scenarios, the mother would be at high risk for going for a premature labor. Okay. Then next is multiple pregnancies. Okay. So we all know that twins or triplets are associated with premature birth. That is because there is lack of space in most of the circumstances because of the excessive amniotic fluid and because of the lack of space in utero, because of the stretching effect of having two or three fetuses, she may go in for a premature labor. Okay. Then next is conception through in vitro fertilization. Again, whenever the mother conceives through in vitro fertilization, most of the times she is either overage or maybe IVF may be associated with multiple gestation. So in either case, she may go in for a premature labor. Then when there is a history of multiple miscarriages or abortions, which may be associated with a short cervix. Okay, or whenever she has any physical injury or trauma or uterine or cervical or placental abnormalities in the mother, whenever there is a history of substance abuse in the mother, when mother's nutritional status is poor, whenever there are infections or chronic conditions in the mother like diabetes or hypertension. Okay, and whenever there is any stressful life event which is happening in the mother, so all these may lead to premature birth. Now we all have studied up till now how do we classify a low birth weight baby, and second is what could be the risk factors. Now coming to the next point, that is how do you identify a preterm baby. Okay, so as I told you, a low birth weight baby may be a term baby or a preterm. He may either be a preterm baby who is born at say 34, 36 weeks of gestation, or the baby may by itself be 38 weeker or 39 weeker, but he's small for gestational age. So in that case, whenever you see a premature baby, whenever you see a low birth weight baby, you have to first differentiate. The first step is to differentiate whether this baby is actually a premature baby or whether this baby is term but SGA baby. Why? Because the challenges would be different in either of the babies. Okay, so if it is a preterm baby, the set of challenges would be different. Okay, in managing a preterm baby. Whereas if it is a term SGA baby, the problems which we anticipate would be different and the management would differ slightly. Okay, so that is why whenever you see a low birth weight baby, you should first identify whether this baby is actually a preterm baby or a term baby. Okay, so how do we come to know whether whether a particular baby is a term or a preterm baby? So the best estimate or the best information about it could be obtained through the first trimester ultrasound. Okay, so whenever the mother has a first trimester ultrasound, in the first trimester ultrasound, the obstetrician or the sonologist usually assesses the crown rump length. Okay, and based on the crown rump length in the first trimester, we which in the first trimester ultrasound, we can estimate the expected gestational age of the baby at the time of birth. Okay, so that is actually the best estimate of the gestational age of the baby. If the first trimester ultrasound, now India is actually a very big country with diverse healthcare scenarios all over the country. So if you are working in a public sector hospital, maybe in a rural setup, in that scenario, your ultrasounds would not be available. So in that case, if you don't have the ultrasounds available, the second method which we commonly rely on is we depend upon the LMP, that is the last menstrual period date, which is told by the mother. Okay, and based on the Nagel's formula, we can estimate the gestational age. So that is another way. And the third way is clinically, when we examine the baby, there is a score which I think most of you would be knowing. That is the expanded New Ballard score. Okay, so this expanded New Ballard score is something which, when we see the baby, we have to apply the score on the baby. And when we apply the score on the baby, there are certain points which we have to, plot, and we have to mark on this score. And based on that, we can estimate the closest gestational age of the baby. Okay, so this is what we call the expanded New Ballard score. Now, as pediatric residents, we expect all of you to at least know what are the criteria which we have to see in a New Ballard score. Okay, and this is something which, when you do or in your day-to-day practice on a routine basis, the more you do, the more master you will become in it. Okay, so I mean, like when I see the patients in my wards or in my NICU rounds daily, sometimes it happens that we don't, as consultants, we don't have that much of time. So just by seeing the baby, because we have seen so many babies, we just by seeing a baby for say 2 minutes, 5 minutes, I can get an idea. Okay, this is a preterm baby or this is a term baby. But for you, when you are beginners, it is advised that you should have the habit of uh, plotting the New Ballard score for all the babies which you see. Okay, or at least for as many babies as possible which you see. Okay, because the more you do it, the more practice you do, the more master you will become in it. Okay, so you for that we use an expanded New Ballard score. Now this expanded New Ballard score, it has both. It has two set of criteria. One is it has certain physical parameters which we have to look for in the baby, and second is there are certain neuromuscular criteria which we have to look for in the baby. Okay, so based on this physical and the neuromuscular criteria, there is a chart. I think most of you would be knowing it. So there is a chart for the Ballard score, and when we examine the baby for physical and the neuromuscular criteria, we score the baby. Okay, based on the score, finally we add up and we find a total score. That total score would correspond to a particular gestational age, and based on that, we come to know what is the gestational age of the baby. Okay, so when we are seeing or examining a baby, there are certain physical differences. Okay, so when we examine the baby for physical parameters in this expanded New Ballard score, there are certain differences between a term and a preterm baby as far as the physical criteria are concerned. Okay, so for a preterm baby, the skin would be, so these are actually the 6 points which we need to look for whenever we are examining a baby for Ballard score. Okay, and so in each of these, I have just highlighted or I have just pointed out the differences. So for a preterm baby, the skin would be thin, transparent, and gelatinous, whereas for a term baby, it would be thick and keratinized and non-gelatinous. the hair, preterm babies, they would have a lot of thin, fine hair on their skin, which we often call the lanugo. Whereas as the baby reaches term gestation, these lanugo are replaced by bald areas on the skin. Okay. Then comes the ear cartilage. Ear cartilage in preterms would be very, soft, and it is something which is not well developed. As a result, whenever you pinch the ear or whenever you try to pinch the cartilage of the ear between your thumb and the finger, okay, there is a slow recoil whenever it is a preterm baby, whereas if it is a term baby, there is an instant recoil because the cartilage is well developed. The recoiling capacity becomes good. Okay. Then coming to the breast nodule, the breast nodule for a term baby it would be more than 5 millimeters in size, whereas for a preterm baby the breast nodule, when you measure the breast nodule between the two fingers, okay, the size would be less than 5 millimeters in a preterm, and it will be more than 5 millimeters in the term baby. Coming to the next point, that is the creases on the sole. Okay, so whenever you examine the sole of a baby, if it is a preterm baby, there would be thin creases which are either present on the there is some disturbance. Yeah, can we mute the participants? There's some disturbance. I think somebody is unmuted. Few of the participants are unmuted by mistake, maybe. Can we mute them? Is it possible to mute the participants? There is a lot of background noise. I think it is. Can someone help me with muting the participants? Someone from the host side, clarinet team. Yeah, I think that's fine. So the breast nodule, as I told, it would be less than 5 millimeter in a preterm baby, and it will be more than 5 millimeter in the term babies. Okay, and for the when it comes to the sole creases, the creases of the sole, they would be present only over the anterior 1/3 of the sole in case of preterm babies, whereas for term babies, the sole creases would be present over either the anterior 2/3 or they may be present over the entire sole. Okay, then coming to the external genitalia, for if it is a preterm baby, if it is a preterm baby and if it is a male child, the scrotum would not, the testis would not have descended into the scrotum, and also the scrotal rugosity would be not very good, or it will be just a faint rugosity. Whereas if it is a term baby, you could appreciate or you could palpate the testis inside your scrotum, and also it would be the scrotal rugosity would be good. Whereas if it is a female child, in a female child, the labia majora and minora would be, widely separated. If it is a preterm baby, the labia majora and minora are widely separated, and the clitoris is very prominent. Whereas if it is a term baby, the labia majora and minora are actually well opposed, and they cover the introitus. Okay. Right, not moving. Yeah. So then coming to the problems of a low birth weight baby, what are the problems we expect? Okay, so based on these criteria which I told earlier, okay, so these are the physical criteria to differentiate between the term and a preterm baby. There are certain neuromuscular criteria as well, which we can apply, and based on that we can decide whether the baby is a term baby or a preterm baby. Okay, I think all of you must have some idea about those neuromuscular criteria as well. So those basically include the square window, arm recoil, scarf sign, popliteal angle, heel to ear, okay, and ankle dorsiflexion. So those are some of the ways, neuromuscular criteria, which we can use to differentiate between the term and a preterm baby. Okay. So now, once we have applied the Ballard score, or maybe once with the help of LMP, or maybe with the help of the first trimester ultrasound, we have to first differentiate whether the low birth weight baby which we are seeing is actually a term baby or a preterm baby. If it is a term baby, it is most likely SGA, that is small for gestational age. Now, what are the problems which we could anticipate in these low birth weight babies? So first and foremost is asphyxia. Okay, why asphyxia is very common in these low birth weight babies is because see usually what happens is during the in utero phase, it is the placenta which is taking care of the gas exchange function for the fetus. Okay, so fetus is not breathing in utero, or the gas exchange for the fetus is not happening at the level of lungs, but it is happening at the level of the placenta. Okay, so basically your placenta acts as the lungs or the source of gas exchange for the fetus. Now, whenever these babies were born low birth weight, either because of prematurity or because of SGA, in either of the circumstances, what happens is as soon as the baby is born, maybe the lungs would not be so mature, and because of which they may have some difficulties in transition. Okay, so that is why these babies are at a high risk for asphyxia. Next is they are at high risk for hypothermia. The reason why hypothermia is very common in these premature babies or low birth weight babies or SGA babies is because one is because they have a larger surface area for the head as compared to rest of the body. Okay, so head surface area is relatively larger as compared to the rest of the body. That is why they tend to lose more heat through the head. That is one of the reasons. Second is their skin is very thin. Okay, they have lack of subcutaneous fat. Because of the less subcutaneous fat, there are more chances of heat loss occurring through the level of the skin. Okay, third is there is lack of brown fat. Okay, so these babies who are born low birth weight, either premature or SGA babies, they have less of brown fat. As a result of this decreased brown fat, the brown fat is responsible for non-shivering thermogenesis. Thermogenesis means generation of heat. Okay, so because brown fat is less, these babies are not sufficient enough to generate good amount of heat by themselves. Whenever they are exposed to cold environment, they tend to lose heat, and that is why they are at high risk for hypothermia. Next is these babies are at high risk for feeding difficulty. Why feeding difficulty? Because see, a term baby would be able to feed directly through the mother's breast because the sucking swallowing coordination is well developed, and the baby actually has to coordinate the sucking and swallowing with breathing. Okay, so that coordination is something which develops only beyond 34 weeks of gestation. Okay, so whenever a baby is born low birth weight, most likely premature, or even if it is an SGA baby, what happens is sometimes this coordination would not be well developed. Either the sucking efforts are altogether poor, even if the baby has some sucking efforts, the coordination between sucking, swallowing, and breathing would not be good. So because of that, these babies are at compromise in taking the breastfeed directly. So they may have some feeding difficulties. You may need to give some assistance to these babies for feeding. Okay, next is respiratory distress. So as I told you, the since the baby is born either premature or small for gestational age, the fetal lung maturity would not be sometimes adequate, and as a result, these babies are at higher risk for respiratory distress. Also, these babies are at high risk for hypoglycemia, hypocalcemia, and other electrolyte abnormalities. So, hypoglycemia and hypocalcemia, why it happens in a low birth weight baby? So, hypoglycemia predominantly happens because the hepatic glucose stores would be very less. Okay, so a term baby is not at a high risk for hypoglycemia because even if a term baby you give less of feeding, what happens is okay, these term babies they have some amount of glycogen stores in the liver. So whenever you're not feeding the baby, this glycogen in the liver gets used up and it metabolizes so that the blood sugar levels stay normal. But when it comes to a preterm baby or a low birth weight baby or a small for gestational age baby, what happens is because of the low birth weight or because of the prematurity, their hepatic glycogen stores are very less. As a result, these babies are at high risk for hypoglycemia. So as and when or whenever you skip feeding or whenever for some reason you are not able to feed these babies, their this thing sugars they start decreasing. Okay, also they are at high risk for hypocalcemia because calcium, usually most of the fetal accretion of calcium, okay, so most of the transfer of calcium from the mother to the fetus, it happens during the third trimester. Now, if the baby is born low birth weight, either because of prematurity or small for gestational age, the calcium stores which the baby should have acquired from the mother would not be sufficient. Okay, and as a result, they are at high risk for hypocalcemia. Also, they are at high risk for certain electrolyte abnormalities in the form of hyponatremia because their kidneys are immature, so they tend to lose more sodium in the urine. Okay, as a result, these babies are at more risk for hyponatremia of prematurity. Okay, then these babies at the same time, because of their low birth weight and because of their prematurity, these babies are at high risk for infections. They are very vulnerable for infections because their immunity is not well developed. Okay, the transfer of uh, a term baby is actually protected from infections more protected from infections as compared to a preterm baby. Why? Because the immunity in a term baby is relatively good. Most of that immunity in a term baby is actually because of the passive immunity. That is, the baby acquires that immunity from the mother. Okay, so it is only during the last trimester or a weeks or few weeks before the delivery of the baby when there is passive transfer of antibodies from the mother to the fetus, and this passive antibodies which are transferred will help to protect the fetus or help to protect the baby once the baby is born. Now, if the baby is born premature or low birth weight, this transfer of antibodies from the mother would be low, and that is the reason why these babies are at high risk for catching infections. Okay. At the similarly, they are at high risk for developing jaundice because the liver is also immature. Okay, the enzyme systems for liver for breaking down the RBCs and for metabolizing heme are immature, and as a result, these babies are at high risk for developing jaundice. Uh, Similarly, they are at high risk for developing brain injury because the capillaries in the brain, the capillary network in the brain is actually very fragile. As a result, whenever they are exposed to any form of stress in the form of birth asphyxia or in the form of shock leading to inotropes, or whenever they are exposed to high positive pressure ventilation, all these, even a little bit of stress, maybe a passive hyperextension of the neck or hyperflexion of the neck, all these can hamper the blood supply to the brain, and they may lead to rupture of these capillaries leading to intraventricular hemorrhage. Okay. Then also these babies are, because their CNS is immature, the respiratory control may sometimes not be proper. As a result, they may be at risk for apnea of prematurity. They are at high risk for anemia of prematurity. Why? Because the RBCs. Okay. Normally, in all our bodies, what happens is the older RBCs they break down, the newer RBCs keep on forming, and that is what keeps the balance between the older and the newer RBCs. But in a preterm baby, what happens is the older RBCs would start breaking down fast, whereas the newer RBC production capacity would be low. Okay, I'm just speaking in very basic terms because I don't want to confuse you at this point of time. So that is why these babies, the RBC breakdown is high and the production is a little bit low. That is why they are more prone to develop anemia of prematurity. Okay. Also, because the retina is immature and because these babies are most of the times because of the respiratory morbidity or because of the infections, they are exposed to high oxygen concentration or maybe blood products. So all these high oxygen concentration, prolonged ICU stay, or sepsis, or hypoglycemia, or anemia, all these whenever they happen, they may cause some hypoxic stimulus to the retina, because of which the retina, the immature blood vessels of the retina, they go for abnormal vasoproliferation, leading to retinopathy of prematurity. At the same time, all these prematurity and all the stresses which the baby has to go through in the ICU may lead to hearing loss, or sometimes they may have a poor long-term neurological outcome in the form of cerebral palsy or behavior or cognitive delay. Okay, so these are all the problems we may anticipate with a low birth weight baby. There are certain set of problems which we anticipate specifically in an SGA baby. Okay, so these are all term babies, but they are born small for gestational age because their in utero growth was compromised for whatever be the reason. Sometimes there may be a fault in the placentation. That is, your placenta and the umbilical cord are not properly formed. That is why the nutrition to the fetus is compromised over a prolonged period of time. Sometimes maybe because of the maternal conditions like diabetes or hypertension or some other problems with the mother, the blood supply or the nutrition for the fetus becomes compromised, and as a result, the child may be small for gestational age. Sometimes it may be because of some fetal problems. Okay, so fetal problems could be whenever the child is actually having a chromosomal anomaly, or some genetic abnormality, in that case also the child may be small for gestational age. That is, he will not grow to his full potential in utero. Okay, so whenever a baby is born small for gestational age, there are high chances that there may be some amount of fetal distress. That is, whenever the fetus is in utero, there is some form of distress or some compromise to the fetus in utero. There may be in utero passage of meconium. Now, again, in utero meconium passage is because of the fetal distress only. There may be perinatal asphyxia, that is, at the time of birth, these babies may not cry, the oxygenation may get compromised. Okay. And they may have certain problems like polycythemia, that is your increased this thing, PCV or the hematocrit in the blood. Okay, they may have some risk for hypothermia, hypoglycemia, and also they are at high risk for congenital malformations. So now coming to the management of the low birth weight babies. Okay, so till now we have discussed briefly about I mean, what could be the reasons for a baby being low birth weight, and also what are the potential problems we could expect whenever we are dealing with a low birth weight baby. Now, coming to the main part of the talk today, that is, how do you manage these low birth weight babies? Again, the management of low birth weight babies is sometimes very complex. Sometimes it depends upon what is the condition of the baby, what is the gestational age of the baby, and what is the clinical state of the baby. But I mean, you cannot generalize these points which I will be discussing to all the babies. Okay, but I'll try to simplify it as far as possible. So when we talk about the management of the low birth weight babies, there are certain basic points you have to keep in mind. Okay, so you have to keep in mind what are the problems. Okay, only when you know what are the problems this baby can have, you can manage these. Okay, you can be vigilant about these problems. Okay, so first of all, whenever you want to manage a low birth weight baby, first is we have to discuss about the delivery of these low birth weight babies. Okay, so regarding the delivery, the delivery for these low birth weight babies should always happen in a setup where they can be properly cared for. Okay, so now not all the hospitals would have the infrastructure needed to care for these low birth weight babies. So you cannot expect these type of low birth weight babies to deliver in a PHC or a small hospital or a small nursing home, because these babies are very delicate and sometimes they need to require intensive care immediately. So if the baby is born in a PHC or in a small nursing home, by the time they shift the baby to a tertiary care center, the baby would already be compromised. So that is why it is ideal that whenever you are anticipating a preterm delivery or whenever you are anticipating a small for gestational age baby to get delivered, ideally these babies should be transferred in utero. So best form of transfer is actually the in utero transfer. Whenever possible, mother comes to you in preterm labor, or you know that this baby who is preterm or this baby who is SGA is about to get delivered, you should transfer the baby in utero. Okay, so before the mother delivers, you should transfer the mother to a hospital which can care for these low birth weight babies. So ideally, we should transfer them in utero. Second is, as I told you, it should be conducted in those facilities where established newborn care facilities, especially for these low birth weight babies, are available. Okay, so if you're now all of you, I think most of you are actually residents in medical college. So medical college is always equipped to care for these low birth weight babies, but that may not be the scenario in some small nursing homes in private sector, or may not be the scenario in some PHCs. So that is why if a high risk delivery is anticipated, they should immediately send the mother in utero, because if the delivery happens in a controlled environment or in a situation or in a hospital where immediate low birth weight care can be initiated, the outcomes are definitely much better as compared to those babies who have delivered outside and then they are transferred to the a particular health facility. Okay, so always you should try to transfer the baby in utero to a higher center if at all your center is not equipped to care for the low birth weight babies. So that is the first message. Second is, where the baby has to be managed. Okay, so whenever a baby is born, okay, if the baby is otherwise well and the baby's weight is more than 1.8 kgs, that is more than 1,800 grams, and the gestational age you calculate and it comes to be more than 34 weeks, you can shift the baby to the mother side. Why? Because as I told you, beyond 34 weeks of gestation, there is good coordination between sucking, swallowing, and breathing. Okay, so a baby who has crossed 34 weeks of gestation, we expect that he would be in a proper, he would have sufficient maturity to, directly suck at the breast or to take the feeds directly. So in such cases, you can shift the baby to the mother side in the postnatal ward. Only thing, you have to monitor such babies. ऐसा नहीं है कि you shift the babies and then you forget them or you don't see them. These are the babies who require some assistance most of the times. So that is why when you shift the babies to the postnatal ward along with the mother side, uh, it is our duty or the duty of the postnatal ward residents or the postnatal ward treating doctors to, every now and then they should go and assess the baby at least twice or thrice a day. They should go and assess the baby. They should assess how the mother is taking care of the baby. They have to talk with the mother. They have to tell her about what are the problems which are anticipated in this low birth weight baby and how she has to take care of the baby. Okay, so if the baby is more than 34 weeks or more than 1.8 kg, you shift the baby to the mother side. But if the baby is less than 1.8 kg or if the baby is less than 34 weeks of gestation, you have to admit the baby to your SNCU. Okay, that is your newborn care unit. Why? Because these babies may have some compromise. These babies may not be ready to, even if there is no respiratory distress, even if the child is crying vigorously, if his saturations are good, everything is fine. But this baby still may not have this required maturity to directly take breastfeeding. Okay, so in that case, you need to give some specialized assistance to the baby in the form of RT feeding or maybe in the form of katori spoon feeding or whatever method. Okay, or palade feeding. So that is why these babies they need to be cared for in the newborn care units. Okay, so after you have decided that you have to bring the baby to your SNCU or you have to shift the baby to the mother side, next important aspect which comes for the care of all these babies is you have to keep the babies warm. Okay, so thermoregulation is one of the most important aspects when you are caring for these low birth weight babies. Okay, so whenever you are asked to, care for, asked about the care for the low birth weight babies, thermoregulation would, I think, be the first point you should focus upon because these babies, as I told you, they have a very thin skin, they have less subcutaneous fat, they have less of brown fat, they have a higher body surface area. So because of all these handicaps, they are at high risk for hypothermia. So until and unless you take care of the thermoregulation, you are not going to ensure good outcomes for these babies. So that is why these babies thermoregulation is very important. Now thermoregulation is something which you have to ensure at all points. It is not only inside your NICU. Thermoregulation is something you have to take care whenever you are going to attend the delivery in the delivery room. So in your labor room or the obstetrics OT room also, wherever C sections are happening, in that areas also, it is our duty as pediatricians or as pediatric residents to make sure that the temperature regulation is being done for the babies. Okay, so even if you are there in the delivery room, you have to ensure that the temperature of the delivery room is around 26 to 28 degrees Celsius and not below that. Okay, I have seen certain labor rooms, whenever you enter the labor room, because it is too hot, because it is too congested, the obstetric nurses, they sometimes would decrease the temperature to 20 degrees Celsius because it is too hot summer outside and the room is very congested and there is no ventilation. So they want, they would keep the AC at that. So that is definitely not advisable, especially when you are caring for these low birth weight babies. We have to ensure that the delivery room temperature is around 26 to 28 degrees Celsius. Secondly, whenever you need to resuscitate these babies, you should make sure that you resuscitate them in the radiant warmer. Okay, if you are not resuscitating these babies, if the baby is otherwise healthy, say the baby, 34 weeks of gestation and 2 kgs birth weight, otherwise healthy, crying at birth, and there is no other, problem with the baby. For such babies, you should allow the baby to be on the mother's abdomen. Okay, you should go for early skin to skin contact. Okay, so that is very important because that ensures good thermoregulation. It prevents hypothermia and it increases the bonding between the mother and baby. If the baby is sick, having some respiratory distress or not cried at birth or whatever be the problem, you shift the baby to the radiant warmer. Okay, so you have to ensure that even in the delivery room, you have to take care of thermoregulation. Second is whenever the baby is inside your NICU, all of us know that we have to take care for such babies either in the radiant warmer or in the incubator. Okay, so we have a few devices to ensure thermoregulation. Most commonly, we prefer to use a radiant warmer, especially in the Indian setup and especially in the public sector hospitals. But and one more way by which you can ensure thermoregulation for our stable low birth weight babies is by KMC. Okay. So those are some of the ways by which you ensure thermoregulation inside the hospital. This thermoregulation thing has to continue even at the home. So it is not only inside the hospital, but you have to teach the mother that whenever the baby is discharged and the baby is at home with the mother, okay. So suppose a baby is born at a weight of 1.5. Now you cannot keep this baby till he reaches a weight of 2.5 and then discharge. Sometimes we discharge the babies whenever they reach 1.8, 1.9 kgs. So still the baby is low birth weight, still he is at risk for hypothermia. So you have to counsel the mother in such scenarios that the mother, has to keep the baby next to her. They should not be in the separate room. They should be in the same room. The baby has to be well clothed. That is, she has to ensure that the cap, socks, mittens, and shirt and everything she has put on properly. And if it is cold outside, she has to put on a blanket. Okay, and also you have to train the mother to look for cold stress. That is, you have to train the mother to assess whether the hands and feet they're cold to touch or not. Okay, so all these things you have to ensure for caring for a low birth weight baby. Next, most important aspect. So one aspect which we talked about was about the thermoregulation. The next most important aspect, which I think all of us would be struggling in our NICUs, is regarding the feeding or the nutrition of these low birth weight babies. Okay, why? Because see, all these low birth weight babies, they are at a nutritional emergency. Okay, so even if the baby is a premature baby or a baby is a term baby who is small for gestational age, the low birth weight indicates that the nutrition is somewhere compromised. Okay, and until and unless you take care of the nutrition part, you are not going to produce good outcomes for these babies. It would never happen, sometimes as pediatric residents, when I was a resident, I used to get fascinated by ventilation, central lines, and other hi-fi things. Because of all those things, we very conveniently skip something which is very basic and something which is definitely going to produce some very good outcomes, and that is nutrition and feeding. Okay, so nutrition and feeding is definitely one of the very important aspects when you are caring for these babies. Until and unless you ensure proper adequate nutrition for these babies, your outcomes are not going to be good. Okay, so whenever you are caring for these babies, for the low birth weight babies, what regarding the feeding, there are certain things we have to decide. First is, what is the type of feed we want to give to these babies. So ideally for all the babies, the best milk is always, keep this in mind, the best milk for all the babies is MOM, that is mom, that is mother's own milk. So for any baby, the best milk you can give or the best nutrition you can give to the baby is through the mother's own milk. That is one point. If the mother's own milk is not available, what we prefer is we go for a donor human milk. Okay, so pasteurized donor human milk. There may be some of the medical colleges where you have a milk bank. Okay, so if the milk bank is there, we prefer to give a pasteurized donor human milk. Okay, if the milk bank is not there, okay, the last option comes either the formula feeds, but I am totally against formula feeds. We prefer to go for either the mother's own milk or the pasteurized donor human milk. Okay, now sometimes it would happen, you would be seeing in your day-to-day practice that mothers would come to you and they would tell that they are not having adequate secretion, or maybe they are too tired to express the milk. It becomes our duty as pediatric residents, because see, we are concerned with the baby's nutrition and the baby's outcome. And until and unless you take care of the mother's this thing, until and unless you take care of the nutrition through mother's milk, you are not going to produce good outcomes. So in such case, it becomes our duty to motivate the mothers, counsel them about the importance of breast milk, and to ensure that they express enough breast milk. You have to answer all their queries. You have to make them understand why they are having less milk in the initial few days, and you have to make them understand the importance of giving their own milk to the baby. Once you are able to motivate the mothers, your job is done. Then they would take care of their baby by themselves. Okay, or they have to be motivated enough to come to the NICU and express the milk for their babies. Okay, so that is a challenge. But if we if we have a good system for ensuring this, our outcomes would definitely be the best. So that one thing is the type of milk we want to give. Second is, what is the method by which you want to give. Okay, so as I told you, best milk is the mother's own milk. But suppose if the baby is born at 1.5 kg with a gestational age of say 32 weeks, that baby may not be sufficiently mature to give or take the breast milk on his own. So such cases may require some specialized assistance on our part. Okay, so I have decided the initial feed we want to give to the baby. So I have decided the initial feed we want to give to the baby. So if the baby is less than 1.2 kgs birth weight or less than 30 weeks of gestation, we prefer to start them on IV fluids, though we start with something which is called as minimal enteral nutrition. So initially we start at minimal enteral nutrition, or what you call trophic feeds. Once you start them on trophic feeds, you gradually increase the feeds if they are tolerating, and then you taper and stop the IV fluids. Eventually you shift them to gavage feed, and then by 1 to 3 weeks, once the baby is mature enough and once the baby is out of other problems, you shift them to katori spoon feeds, and then finally to breastfeeding after 4 to 6 weeks. Similarly, if the baby is born between 30 to 34 weeks of gestation, the initial method of feeding would be a gavage feeding because, as I told you, the suck swallow coordination would not be very adequate in these babies. So initially, we go for a gavage feeding. Then, once they are comfortable with that and they are tolerating feeds, then slowly we try to introduce katori spoon feeds. And once they are convenient or comfortable on that, next we introduce is breastfeeding directly once the baby attains sufficient maturity, right? And if the baby is born more than 34 weeks of gestation, definitely the first feed you go for is directly breastfeeding. Okay, so we have discussed about the type of feeding to be given. Next is the mode or method by which we have to feed these babies. Third is how frequently you should feed the baby. Okay, so again, you have to counsel the mothers. It is our duty as pediatricians or as pediatric residents that we have to counsel these mothers that they have to feed the baby once in every 2 hours. Okay, and they have to be encouraged about nighttime feeding because most of the times it happens that the mothers are not motivated enough to feed the baby at night. Okay, because maybe of the pain at the time of delivery or postnatal stress or anxiety, they may not be comfortable or they may not be motivated enough to feed the baby at the night time. So it is our duty as pediatric residents or as pediatricians to counsel them, to educate them about the importance of nighttime feedings, and that they have to make sure that they feed their baby at least once in 2 to 3 hours. It is preferable to go for 2 hourly feedings. Okay, and at the same time, you have to assess how much milk they are getting. Okay, so this was about the type of feeding. Okay, then if at all the baby is sick, okay, so there may be certain babies who are sick enough and they cannot be initiated on full feeds directly. Maybe the child is on ventilator, or maybe the child is on CPAP, or maybe having poor perfusion or having sepsis. So whatever be the reason, sometimes these babies cannot be started on full feeds directly. In that case, we start them with the IV fluids with a rate of 60 to 80 ml per kg, and then gradually every day we increase the fluid rate to 15 to 20 ml per kg. Okay, that has to be done only when you are getting a good weight loss. Okay, you have to get some initial weight loss. If the baby's birth weight on day one is 1.3 kg, on day two, if the child is not losing weight and if this weight is instead of 1.3, it becomes 1.35 or 1.37, then in that case, I will not increase the fluid rate. I'll decrease. I'll continue with the same fluid. Okay. Then what is the normal weight pattern? Okay, this is very important for us to know. As I told you, the baby has to lose some 1 to 2% weight every day initially, and at least for the first 4 to 5 days. And the cumulative weight loss has to be somewhere around 10% in the first week of life. Once the baby reaches around that much weight loss by day 7, after that we expect the weight to start gaining again, and by 14th day we expect that the baby regains the birth weight. Okay, once the baby regains the birth weight, then after that the baby should have a continuous weight gain, and the optimal weight gain is around 15 to 20 grams per kg per day. Okay, so we should not expect a huge weight loss, or the weight loss would always be depending upon the how much is the baby's current weight. Based on that, we should expect, or we should target the weight gain which is expected over the next few days. And also we should not be happy with 2 grams 3 grams weight gain. The weight gain, ideally, if at all it is if at all you are providing good nutrition, the weight gain should be around 15 to 20 grams per kg per day. Okay, and once you are taking care of the feeding part, what happens is these babies, they are at a nutritional compromise. There, as I told you, because the baby is born either premature or small for gestational age, whatever the nutrients the baby should have got from the mother's milk, or whatever the nutrients the baby should have got from the mother's body during the last trimester. Okay, if the baby is born say at 32 weeks of gestation, so there is a deficit of 8 weeks. Now, in that 8 weeks, we expect a good transfer of nutrients from the mother to the fetus. Now, because the baby is born premature, these nutrients would not get transferred from the mother to the fetus. As a result, the child would be at a risk of deficiency of these, essential nutrients, and that is why sometimes we need to supplement these nutrients additionally. Okay, so vitamin K is a universal practice for all babies, irrespective of the weight. We have to give vitamin K. If the baby's weight is less than 1 kg, we give it 0.5 mg. If it is more than 1 kg, then we give a dose of 1 mg for all the babies. Okay, even if the baby is normal birth weight or a low birth weight or whatever be the weight, and whatever be the gestation, irrespective of that, for all babies, we have to give vitamin K at the time of birth. Second is, if the baby is born premature, even for term babies also there is a recommendation to go for vitamin D supplementation, because the breast milk is actually deficient, and most of the Indian mothers are as such deficient in vitamin D. And we have to rely on vitamin D for these supplements. Okay. And the preterm babies or the low birth weight babies, they are at risk for anemia of prematurity. That is because their iron stores are very low. Okay. And that is why we need to supplement them with additional iron at 2 to 4 mg per kg per day. Okay. And that has to be started once the baby crosses the age of 2 weeks. Again, multivitamins also we need to supply them. Okay, the multivitamin drops which are available in the market, the composition is such that 1 ml would suffice the recommended dietary allowance. Okay, so once the baby attains a feed of 100 ml per kg per day, we tend to provide multivitamin drops for these babies. And also calcium and phosphorus supplementation is started once the baby attains 100 ml per kg per day feeds. Now calcium we start at 120 to 140 mg per kg per day, and phosphorus we start at 60 to 90 mg per kg per day. Okay, so these are all for preterm low birth weight babies, extra supplements which we need to give. Okay, so apart from till now I discussed two important aspects of care for these low birth weight babies. One was about the thermoregulation, second is the nutrition. Apart from that, there are certain other topics which I would like to discuss. So one important aspect I think all of us would agree is in all the NICUs. See, all other branches may not be very much cautious, though they should be cautious, but they may sometimes not be very cautious about asepsis. But NICU is one area, or neonatal care is one area where you have to have a strict focus on asepsis. Okay, asepsis and hand hygiene. Those are two simple things which they would improve your outcome. And if you don't take care of these two things, your outcomes are definitely going to be very bad. Okay, so whenever we are talking about the care of the low birth weight babies, as I told you, you have to take care about thermoregulation, you have to take care about your nutrition. Also, you need to take care about hand hygiene and asepsis. Okay, so it is before you handle these babies, before you touch these babies, you have to make sure that if you have entered the NICU or the newborn care area from outside, you have to ensure that you do a good proper hand wash with a soap and water. Okay, if you are already working inside the nursery, and in between the babies also, before touching second baby, after touching the first baby, you have to ensure that you do a good you use hand rub and do a good hand rub, hand hygiene using the hand rub. Okay, so that is very important. So hand hygiene is very important. Asepsis while handling these babies is important. You should not touch the babies very often, or you should not disturb these babies. Okay, you have to monitor them, but that too, that is the art which we need to learn all as pediatricians and neonatologists. That you need not disturb those babies very often, but you should learn the subtle art of monitoring them. Okay, when you observe the baby frequently, you will come to know any change in the behavior, and that would help you to pick up the deterioration early. But you should not touch them very often until and unless needed. Okay, so that is asepsis. You have to take care. Also, these babies are at high risk for hypocalcemia. So for that, we need to hypocalcemia. So for that, we need to, one thing is we need to supplement calcium for all these preterm babies, especially when they are on IV fluids. We need to give IV calcium along with the fluids. Once they attain full feeds, that is 100 ml per kg per day of feeding, we tend to start calcium supplements, as I discussed earlier. Also, these babies are at risk for hypoglycemia. So for that, we need to monitor these babies' blood glucose levels at frequent intervals. Okay, and whenever the hypoglycemia is picked, we need to either give a, if it is asymptomatic hypoglycemia, we give a trial of feeding and then we assess. If it is symptomatic hypoglycemia, we give a bolus, glucose bolus, and then we start a glucose infusion rate. Okay, so that is you have to take care about the hypoglycemia aspect, hypocalcemia. Then you have to take care of the thermoregulation. You have to take care of the nutrition, and along with that, you have to take care of the infection prevention. So these are some basic steps which you need to ensure while caring for these babies. Once we have ensured proper care, okay, one important aspect is also the respiratory care, because most of these babies would have some sort of a respiratory compromise, and they may need some admission to the NICU for some respiratory care. So when you are caring for these babies, you should always make sure that you have to keep their oxygen saturation levels always less than 95%. Okay, you should not give free flow oxygen and try to attain oxygen saturations 98, 99 or such high ranges. Okay, so because oxygen is a drug. Okay, we have to understand that when you are caring for these babies inside the NICU, oxygen is a drug. You cannot use it. I mean, people who are working in adult ICUs or who are working in medicine wards, they are very casual with using oxygen. But we as pediatricians and neonatologists, we have to be judicious in using our oxygen, because excessive use of oxygen can lead to a lot of problems in these newborns, such as chronic lung disease, or it may lead to retinopathy of prematurity and other problems also. So that is why we have to use the oxygen judiciously. We have to target our oxygen saturation somewhere between 91 to 95%. It should not go beyond 95%. At the same time, we have to avoid fluctuations in the CO2 levels, that is hypocarbia and hypercarbia. Both have to be avoided, especially when the child is on invasive ventilator. Okay, so whenever you are ventilating a child for some reason, suppose the child had RDS or the child was asphyxiated, whatever be the reason for which you have intubated and whatever the reason for which you are ventilating the child, it very often happens that we take care of the oxygenation part, but we sometimes tend to neglect the CO2 part. Okay, and we are not taking care of the uh, CO2 levels of the baby. So both hypocarbia and hypercarbia are detrimental to the baby. They can lead to brain injury to the baby. So that is why you have to be very cautious in handling these babies. Okay. Once you take care of all these aspects, the next part or the last few slides would be about the discharge planning. So when would you plan to discharge these babies, or when would you plan to send these babies home? So we have taken care of nutrition, thermoregulation, all the other tiny aspects which are there for the care of these babies. Next important part is when do you plan for the discharge of these babies? So they can be discharged only when they have a weight gain of consequent weight gain for at least 3 consecutive days. Okay, so daily of 15 to 20 grams per kg per day, that is ideal, and that has to happen for at least 3 consecutive days. Second is the mother has to be confident in feeding the unit. Okay, I mean, because she is the primary person who is going to look after the baby once you send them home. So that is why you have to make sure that the mother is confident. Okay, it is not about the baby taking the spoon feeds well, or baby taking paladay feeds well, but it is the mother who has to be confident, and she has to be sure that she will be able to take care of the baby properly at home. Okay, then you have to start the nutritional supplements and explain it to the mother how frequently the supplements have to be given and in what dose. That has to be explained to the mother. The first immunization has to be complete before discharge from the hospital, and the methods of temperature regulation like KNC should be well known to the mother. Okay, so once you have ensured all these, then you can plan for discharge of these low birth weight babies. There are certain danger signs which we need to explain to the mothers when we are discharging them, when we are discharging the babies home. We need to explain certain danger signs, because we have to tell them that if any of these signs, if they are seen, if the mother feels any of these signs, she has to immediately rush to the nearest hospital or to your facility. So those danger signs would include either a feeding difficulty, or fast breathing, or difficulty in breathing, or whenever the baby is warm, that is having fever or is cold to touch, and whenever the mother feels that the child is otherwise dull or sick or unwell. Okay, so in either of these things, she has to bring the baby to you immediately. When do you follow up of these babies, and what do you look for these follow up of these babies? So all these low birth weight babies, whenever you discharge from the neonatal unit, we consider them to be either moderate or high risk. Okay, because because of the low birth weight, they are at risk for developing long term. As I told you in the initial slides only, there is a chance that they may have neurological compromise in the long term. Okay, so that is why we need to have a good follow up of these babies to see whether they are growing properly or not, and also whether if there is any growth lag or if there is any developmental lag. If we pick that up early and if we intervene at an early stage, the outcomes are going to be better. Okay, so that is why we have to ensure that it is not that कि आपने एक बार उसको घर भेज दिया फिर वो वापस कभी ना आया. No, it is our duty as pediatricians to ensure that you have sensitized the mother to come back for follow up. Okay, if you sensitize them properly, they will definitely come back for follow up. Most of the times, the primary reason why most of the patients, especially these low birth weights, they don't turn up for follow up is because we fail to sensitize the parents. Okay, so we have to sensitize the parents to come for a regular follow up, and when they come for follow up, what all things we need to ensure is we have to assess the adequacy of feeding. Okay, we have to assess whether the child is one thing is vitals, we have to assess whether vitally the child is normal or not. Second is we have to assess whether the mother is giving the feeds properly or not, and all the supplements whether she's giving properly or not. Once you do that, third thing what you need to do is you have to ensure growth from the growth chart. Once you do that on a regular basis, you come to know that the growth is faltering or the growth is adequate or not. Once the child crosses 40 weeks of gestation, we consider them to be either moderate or high risk. Okay, we tend to use the WHO MGRS growth charts, which are the standard charts. Okay. Also, along with the growth monitoring, assessment of feeding, and assessment of the vitals of these babies, we need to ensure that we keep on doing the screening because these babies are at a risk for neurological handicap and other handicaps like retinopathy of prematurity or deafness or certain poor neurological outcomes. So they need to be screened for all the abnormalities from time to time basis. So that is why we need to ensure कि जब भी वो follow up में आए, we should do ROP screening, hearing screening, and cranial ultrasound at regular intervals so as to prevent the blindness or hearing disabilities. Okay. And also, as I told you, we have to take care about the immunization. And also, if you do a good systemic examination, we'll come to know any disability in them, and then that can be treated at an early stage by the specialists. Always, I mean, see, we can do our part to take care of these preterm and low birth weight babies, but having said that, it is always better to avoid these premature births as much as possible. Okay, sometimes it happens, in a busy government hospital and public sector hospitals, it happens that sometimes it is an iatrogenic preterm. That is, the mother feels that she is 37, 38 weeks of gestation, and the obstetrics team, without confirming the gestational age, they'll just bring out the baby. And once the baby comes out, we realize, oh, it was actually a preterm and the baby should not have been brought out. Okay. So this is just one example. There are certain other cases also where it is a premature birth. It should be prevented as far as possible. If at all it is something which cannot be prevented, there are certain interventions which can be done to improve the outcome of these babies, such as the antenatal steroids or magnesium sulfate for neuroprotection. Okay, so we should try to do all these things to improve the outcome. Okay. So yes, together we all can provide good care for the low birth weights, and we can ensure proper survival and good outcome for these babies. Why this topic is important as far as we in the Indian scenario are concerned, because see, India is actually the leading this thing country for neonatal mortality. Okay, so for neonatal, as far as neonatal morbidity and mortality is concerned, we are actually the responsible for 1/4 of pediatricians or neonatologists who are working in India. The care for the low birth weight babies is very important because, again, we are a resource limited setting. Sometimes it is not, I mean, we are not full with the resources. We are not at par with the Western countries in some aspects. Okay, but if we follow these simple things, our outcomes would definitely be very good. Okay, so I think we can end. I mean, this is it from my side. If there are any questions, I will be happy to answer. Any questions, you can unmute and ask. Any questions, anybody? There are no questions. I think we can end the talk for today.
તો આમ આવી જા જોઈ લ્યો